All right, I am thrilled to introduce our next speaker, who is Allison Silvers from the Center to Advance Palliative Care, where she's been since 2016, working at the intersection of palliative care, population health, and value-based payment. She's educated payers, policymakers, and programs alike, and has led major initiatives, including the CAPC Payment Accelerator and the Serious Illness Scorecard. Before joining CAPC, she was Chief Strategy Officer at Village Care and helped launch 2 health insurance companies. Allison holds an MBA from Yale and a BS in economics from Wharton. Allison, thank you so much for joining us this morning.
Thank you, Molly. Thank you. I'm really excited to be here. Typically, I've called this as a subtitle, Facts and Stats on Medicare and Medicaid, but I have a new subtitle this year. May you live in interesting times. So let's get started. We're going to start with just some basics. I know there's a wide variety of knowledge about Medicare and Medicaid and payment models. So we'll just go through the basics of Medicare and Medicaid, and I'm going to highlight where there are significant changes with the new law that was passed in July. Sometimes it's called the One Big Beautiful Bill Act, but it actually was the Budget Reconciliation Act. We'll then go into privatization, meaning Medicare Advantage and Medicaid managed care and what's going on in that space, and wrap up with just some basics about alternative payment. So let's dive into, this is the facts and stats part of what I'm going to cover. Who pays for what, where, when, and what's changing. So just to zoom out for a big picture, this is the most recent data of total U.S. healthcare expenditures and who is actually putting out the money to support it. As you can see, Medicare is 26% of everything, with Medicaid at 22%. It is still the case that employer insurance is the most, covers most of national health expenditures, or I don't mean that. I mean, they have the plurality of national health expenditures, but what's fairly unique in the US is that individuals cover 13%. That's a really significant burden on patients and families. Moving on, I apologize if this is a little too basic, but what we're going to cover primarily today is Medicare and Medicaid. And Medicare is a federal program. So that means that only Congress gets to decide what happens in Medicare. And also CMS has some wiggle room within that. Medicaid is covered by the states. It's a federal and state partnership. So the feds come up with the overall structure that Medicaid must function under. But other than that, the states decide what benefits are covered. They have some options in terms of who to cover with their Medicaid services. And they also have some opportunities to cover additional populations. Oops. I thought I had a pop-up on that. The eligibility is changing significantly on the Medicaid side. So on the Medicaid side, there had been an opportunity to cover people who might not have otherwise been eligible for Medicaid, and the states were able to do that. Populations without sufficient immigration documentation, certain people, adults who don't have a work history, but that is now changing. Just really quickly, by the numbers, Medicaid, including CHIP. CHIP is the child health insurance program for children who are in families that are just above the Medicaid threshold. So 83.3 million lives. It covers about half of all US children, and it's the largest payer for services that include mental health, long-term care, and maternity care. Medicare is 65 million people. We'll get into more stats about who's on Medicare. And then duals are the Medicare beneficiaries usually entitled to Medicare because of age, after age 65. And they are also low income, so they are entitled to Medicaid. So again, for whom, as I said, Medicaid is a program that operates within broad federal parameters, but has options for states. So the requirements, every state is required to cover children who live in families with incomes below 138 of the federal poverty level. There are some options to cover adults without children at the 100% of the federal poverty level, excuse me, or adults as high as 138% of the poverty level. Pregnant women are required to be covered by Medicaid if they're eligible, and 40 states actually cover a year of postpartum. Anybody who is older than 65 or has been confirmed by the federal government to have a disability and therefore receives supplemental security income is also required to be covered by Medicaid. And on the left-hand side are the options. So there are a number of states that allow seniors to be duly covered by Medicare and Medicaid pays the premiums and the coinsurance for the seniors. If there are non-disabled adults, up to 138, and medically needy, which is a wonderful option. New York has it. If your medical expenses are significant, that gets deducted from your income, and the calculation might make you eligible for Medicaid because of that calculation. Now we also have requirements to look at immigration status and work requirements, either proof of working, proof of looking for work, proof of caregiving, and proof of education, being enrolled in education. All states by the end of 2026 will be required to somehow check all that paperwork in order to make sure that Medicaid coverage is going to people that meet these new requirements. And just a quick look at the demographics of Medicare beneficiaries. I think this audience probably knows it pretty well. But yes, the bulk of Medicare beneficiaries are under 65. But there are 12% who are entitled to Medicare because of an ongoing disability for 2 years. And as you know, the stats are growing right now. 10% of Medicare beneficiaries are over 85. Nationally, it's still a primarily white population who's covered by Medicare. But as you can see, there are significant portions of non-white beneficiaries, and that picture is also changing year over year. And in the far right is the chronic conditions. I've had people push back because over here, if you look at number 9, it says only 10% of Medicare beneficiaries are diagnosed with Alzheimer's and dementia. Some of that is due to underdiagnosis and under-reporting of that in the claims, but it's also not as high as some people might think. And same thing, looking at the Medicaid beneficiaries, the majority have at least one chronic condition, some significant rates of diabetes and asthma, heart disease and cancer. And the right-hand chart is a little maybe confusing, but it's not as white as Medicare. And as you can see, for Hispanic beneficiaries and Black beneficiaries, there's disproportionate numbers who are covered by Medicare, excuse me, Medicaid compared to the general population. Okay, for what? Medicare is now 60 years old. And from the very beginning, it had parts A and B, meaning part A was the hospital insurance, which also covered skilled nursing facilities and home-based services, hospice and home health care. And part B covered what's called professional services. So physician bills and ambulances and everything that goes on in the ambulatory setting is usually covered by Part B. Part C we'll get to in a few minutes. That's the privatization of Medicare. And Part D came about in the 80s, covering prescription medications. So for what? I suspect most of you are very familiar with this. So traditional fee-for-service payment, you have to have a specific service that's been approved to be covered by Medicare. Each service is weighted with what's called a relative value unit, and there's other pieces to the calculations, but essentially that's what determines the payment for each service. With the new administration, there's going to be changes. Already in the Medicare physician fee schedule for 2026, they started to chip away at the power of the American Medical Association, who has traditionally defined what the RVUs are. The way the law is written, the AMA makes recommendations to CMS, but CMS has freedom to not take those recommendations. In the past, they traditionally have just taken those recommendations, but even in 26, there's something that they're putting in called an efficiency adjustment, where they're saying, we don't like what the AMA is telling us, and we think it's overinflated, so we're going to knock it down by 2.5% for non-time-based codes. Mostly geriatrics and palliative care build time-based codes, so you should not be subject to the efficiency adjustment, but times go on and there'll be a CMS Medicare payment rule for 27, and we'll see what that holds. And given everything I just said, Part A covers hospitalization and skilled nursing for particular post-acute needs. Part B covers physician services. Medicaid covers a lot of additional services beyond that, but only for the population that's eligible. So there's a lot of gaps that are left, particularly long-term care. And one thing I just really want to stress is that Medicare beneficiaries, family members, don't understand these gaps. There was a survey in Forbes a few years ago, and they surveyed baby boomers, and 56% of baby boomers believe that Medicare would pay for their long-term care. So not only are there significant gaps, but there is a significant misunderstanding of what those gaps are. And I'm sure as you work with patients and families, you come across those gaps pretty often. And there's my stat. Okay, so as I said, Medicare covers a wider range, but this chart is showing what's required. And it's a pretty small subset of services. Um, Everything without an X on it is up to the state to decide whether or not they cover it. Fortunately, for many things like prescriptions and hospice, just about every state does decide to cover it. But if you go outside of New York, you may or may not have the same Medicaid coverage for services. Okay, so the 2025 Budget Reconciliation Act. I showed before they're putting some pretty strong restrictions on who can be eligible for Medicaid, either through outright denial of Medicaid coverage for people without documentation or through paperwork hoops to prove that you are eligible for Medicaid given the new work requirements. As a result, even the federal Congressional Budget Office is anticipating a big loss of healthcare insurance. About 16 million people is what the CBO is estimating. So we can expect hospitals to see a big increase in uncompensated care. Again, because of those Medicaid changes, most post-acute facilities rely on Medicaid funding. And it's going to hit them pretty hard. Plus, there's certain changes. I don't want to get too weedy, but a lot of facilities take Medicaid pending because they can back bill for the days once Medicaid picks in. Now they are no longer able to back bill. So the opportunity for hospitals to discharge people who are Medicaid pending are going to get much, much tighter. I can't think of any facility who can afford to provide free care for days or even weeks. So the anticipated impact is that length of stay in the hospital will increase. And of course, then excessive boarding in the ED will increase because of the long length of stay. There's also a lot of weedy changes to how hospitals are paid for by their states. You might have heard of the provider tax, which was a clever way to get additional federal funding flowing into the state. That has now been stopped. And physician payments. So the law was interesting. They mandated that there has to be an increase in 2026. But going forward, the law doesn't protect 27, 28, et cetera. And given the calculations and how Medicaid calculates what they're going to cover, or the rates that they'll pay for covered services, most people are expecting that there's going to be cuts in future years. The Rural Hospital Fund, this was interesting, and maybe it's not so relevant for folks at Mount Sinai, but I'll go into it for a minute. When the bill was being considered, there was a lot of pushback, as you can expect, from the provider community, the American Hospital Association, et cetera. And particularly calling out how financially vulnerable rural hospitals are, and that the law shouldn't pass. So what Congress did was say, okay, we're still going to pass the law and we're still going to make all these financial changes, but we're going to set up a fund, a $50 billion fund to support rural hospitals. That's all that's in the law. CMS is required to then promulgate regulations that reflect what's in the law. They set up a application for every state to apply for these funds. The applications are due November 5th. First of all, the $50 billion is unlikely to shore up every rural hospital in the United States, and it's unlikely to even be directed directly to those facilities. So most folks are still anticipating a lot of closure for rural hospitals. Already, I was at the CAPSI conference, and somebody from Washington was telling me that they're expecting 14 rural hospitals to close in the next year. Okay, so that was a lot, but I hope that gave you a flavor for how the laws and the regulations on Medicare and Medicaid function. But even more important is that governments are giving control of Medicare and Medicaid to private organizations. And generally, I just like this simple graphic. John Oliver did a great piece on this too, not only for healthcare, but for other things. The government funds a lot of things in this country, and traditionally, the money went directly to hospitals and physicians through fee-for-service billing. But increasingly, the government dollars flow to Medicare Advantage plans and Medicaid managed care organizations. And they are the ones that decide how much hospitals get paid, how much physicians get paid, what they have broad flexibility in terms of what they even cover. And of course, they have the prior authorization tricks to control how their enrollees get access to those services. So where we stand right now, the numbers are a little squishy, but we passed the majority. It's about 55% of Medicare beneficiaries are in a Medicare Advantage plan, and Medicaid, it's even larger. It's 74% of all Medicaid beneficiaries. What it means is that all those beneficiaries do not have complete free choice in what providers they can see and are subject to the prior authorization and other utilization controls. So this has been studied, and now that we're at the majority point, this is getting increasing attention. MedPAC, which is the independent body that looks at Medicare spending and how it's controlled, has estimated that MA is about 122% of traditional Medicare payments. So if the intention was to save money, that hasn't been seen. 22% of Medicare enrollees are reporting care delays, which compares to only 13% in traditional Medicare. So that's a significant, I was going to say, bump up, it's bump down. And access, network limitations are restricting access to some top-rated hospitals. It's been studied in cancer centers, and but we could expect that's true in other illnesses as well. And there's an interesting trend. Black and Hispanic beneficiaries are more likely to be enrolled in Medicare Advantage. So looking at quality metrics, there are a lot of quality metrics where there are disparities that are actually growing because of the movement of certain populations into Medicare Advantage. And not only is it impacting Medicare beneficiaries, but it's impacting hospitals. And these are just some quotes from the CFO report at Becker's. A lot of, let me say, dissatisfaction with the relationships between hospitals and Medicare Advantage. There's actually a good number of hospitals that are ending their Medicare Advantage contracts. And just recently, there was some press about Medicare Advantage plans are also leaving Medicare Advantage. United, Aetna, and there was one other are dramatically shrinking what markets they're offering Medicare Advantage plans in. So this is a really evolving world, and I think neither side is particularly happy, obviously for very different reasons. But may you live in interesting times. Okay, and I'm gonna finish up with payment. I used to say these are new payment approaches. Value-based payment has actually been around for quite a long time now. It still feels new because the culture of US healthcare is still very much embedded in fee-for-service. But I'll go through some basics. And by the way, when you do your evaluations, let me know if this was too basic or not. I tend to want to make sure that everybody understands the basics so they can move forward. But I'd appreciate that feedback. So starting at the very beginning, what is value-based payment? Well, the idea is that value is a function of quality and cost. So, and the higher quality goes for less costs, that in between space is the value. So, I used to teach people, like, think of a I don't know, a Prada suit that's on sale. You know the quality is going to be high, but as you can lower the cost, you're getting even more value for that suit. So same thing in healthcare. If you can deliver phenomenal outcomes at the lowest possible cost, you're generating value. I do want to just put in a note to make sure value-based payment does not equate to risk. There are models of value-based payment that shift risk onto the providers, but there are a lot of value-based payment approaches that do not shift risk. And when the Affordable Care Act first passed, it was heady times, and we're going back to 2010, and the CMS and health policy in general was looking forward to shifting the country from fee-for-service to value-based. And there are still efforts to measure how well we are moving into value-based payment. Just to be a little pedantic, so value-based payment is anything that links the payment to quality. Alternative payment is a little different, and that's why there's different categories. So alternative payment is basically trying to just completely get away from encounters and paying for encounters. So category 3 is, yes, it's alternative payment at the end of the day because you're paid for a certain calculation of cost and quality, but through most of the year and how the calculation gets its data, it's still operating on fee-for-service. Category 4 is, I don't know, I was going to say the Holy Grail, which it has its own problems, but it's the idea that you're paid based on a population. If you have a panel of, I don't know, 200 patients, you just get paid a certain amount of money every month to take care of those patients. Encounters are irrelevant to your payment. So you would use encounters to make sure that you can deliver quality care, but not to generate payment. And this is if you look at what's going on in the world of alternative payment, because there really are quite a lot of approaches out there. So shared savings and losses, the Medicare Shared Savings Program, not 100% sure, but last I checked, Mount Sinai is in the MSSP. That's that category 3. Most clinicians wouldn't even notice. You're still billing fee for service. You're still, optimizing your productivity and your RVUs. But in the background, there's calculations and there might be some additional pressures or incentives to deliver on quality measures. The add-on fee is a really clever way to accomplish alternative payment. We know there's a lot of things that are beneficial for patients, but don't get paid in traditional fee for service. So the add-on fee basically says, okay, each month we're going to give you money to make sure those additional things get covered. A case rate takes it one step further. And like I was saying, you get one payment for each individual that you take care of. Capitation is the word that you also might hear. And lastly, bundle payment is kind of like a case rate, but it's based on a specific period of time, and usually it's usually procedure based. There are bundle payment for chronic illnesses, but the most common, as I put here, is like a hip replacement, a knee replacement. A couple of weeks before the actual surgery, and 30, 60, 90 days after the surgery is just one price. Oops, I can't go forward. Oh, there we go. Whoops, let me just, there we go. Sorry. And in an organized fashion, the CMS Innovation Center, also called CMMI, or the Center for Medicare and Medicaid Innovation, is providing national leadership on alternative payment. Their original, the legislation that established the Innovation Center was part of the Affordable Care Act, and it gave CMS the freedom to develop and test payment mechanisms that are supposed to simultaneously improve quality and lower costs. Achieving one or the other is within its mission as well. But the slam dunk was to do both. And the center also had a mission that if they found something working, then they roll it into Medicare and or Medicaid. That last piece hasn't really happened, at least yet. And actually, many of their models haven't really even achieved the higher quality, lower cost. So it's still an evolving area. In the current administration, things are very quiet on this front. Though I didn't put it in the slide, but there's two models that they did introduce, the new administration did introduce. One is called the Wiser model, which is introducing prior authorizations into traditional Medicare fee-for-service. If you haven't heard about it, I urge you to get familiar with it, because it will impact, if you think you're escaping the prior authorization headaches, if you're working with a Medicare fee-for-service beneficiary, this will now introduce those headaches to the traditional population. But what I have here on the slide are the models that are most relevant to geriatrics and palliative medicine, and that are expected to continue. So the transforming episode accountability model is it's going to be a required bundled payment, and really paying attention to post-acute spending. So if you have control over that, you will probably, they haven't named the states. It's a mandatory model. They haven't named the states and or geographies that will be participating, but you can expect if you are in the mandatory space that will there will be financial pressures to be efficient when you are using post-acute services. The ambulatory special model, specialty model, I don't know if it's special. Right now, they're focusing on patients with heart failure and patients with low back pain, and they're requiring the specialists who care for those patients to meet certain quality metrics and cost metrics. Unfortunately, there is no requirement for palliative care to be involved in the heart failure model, but hopefully there's an opportunity to talk to your cardiology colleagues and help them achieve their goals. Guide, I know that Mount Sinai is participating in the guide model. This is really an exciting model. For the reason I'm going to call out, it's the very first time that Medicare is paying for respite care for family caregivers. And granted, it's just 2 weeks. It's definitely insufficient, but it's monumental that Medicare is even opening up its purse strings for something like that. And lastly, there's the ACO REACH model, which is an accountable care model with greater restrictions and incentives in it. I can't tell reading the CMMI notifications if this administration is hoping to support it or not. There's a special part of ACO REACH which is called high needs, which is your population. And it actually has preliminary data that shows that both cost is being controlled and quality is improving. So rationally, they should look to expand that, but I'm not sure what's going to be happening. And that was the overview of where Medicare and Medicaid stand. I wish I had more knowns about how the new act is going to unfold. The new act was purposely in many of its new requirements not going to take place until the end of 2026 or into 27. So it'll be after the midterm elections that if there are any negative consequences, the country will really be feeling them in 27, 28. But yeah, I'd love to hear your questions or feedback or whatever you got for me.
Thank you so much for that talk. I know you just said it's hard to predict what will happen with the new act, but unsurprisingly, we have some questions about that. So I guess we'll do our best to predict the future. One question is, what do you think clinicians most need to be prepared for with the Budget Reconciliation Act?
So I'm going to start with the most vulnerable. And particularly New York. I have to give a shout out to our state because we have been as generous as I think we can be given limited resources. And we have been covering people who don't have appropriate immigration documentation. And we have used emergency Medicaid to make sure that people can get the care that they need. So I think I'm going to start there as a clinician. You're probably going to start seeing people who just don't have health insurance at all. And if they're in this country, they just might not be able to get health insurance. So I think that's going to be one of the biggest impacts. And I again, to New York's credit, I know there are discussions in the state about how to find money and fill gaps. So that's the remains to be seen part. But I New York doesn't have infinite resources. So I think in that case, I don't have a great answer, but working with social workers, working with REAP, trying to be clever about what you can get for people. I believe there was a recent talk with Brian and Diane Meyer about fundraising. I can see a need for fundraising, not for new programs and exciting innovations, but for let's make sure that some of our patients can get medications, could get, the basics. So I will start there, and I wish I had something more positive to say, but that's going to be the biggest impact. The other impact I mentioned, and I wish I had a solution for this. I worked in long-term care for many years, but because of these different belt tightenings on Medicaid, long-term care facilities are going to be really hurting. Simultaneously, they're also going to be hurting because the immigration crackdowns are either taking people out of the country or reducing the number of people that are coming in. And so many people who work in long-term care are foreign born. So the other thing, I'm sorry to be so gloomy and doomy, but the other thing I'm anticipating is that long-term care facilities would be closing, and or just being very careful about who gets admitted to make their financial numbers work, and that's going to have a big impact on U.S. clinicians as well. If you have suggestions to work in this environment, please send them my way because I'd love to get them out to people.
Yeah. Another related question, sort of thinking more at a systems level, someone asked, with the increase in uncompensated care in hospitals with the act, what do you predict will happen to hospitals and who will eat that cost?
So I'm sorry, I keep laughing because I don't know. I'm probably even more nervous than you than these questions are suggesting. I don't know. I think academic medicine, there will be legislative champions for academic centers. It is a source of pride for many legislators, and it is you have to understand that this country needs to train new clinicians to keep things going. So I do have more hope for academic centers, although I know, like, here's a great example. The administration in their proposed budget, Congress doesn't have to accept it. They had a pretty sizable cut to NIH. At least it was in both the House and Senate. They rejected that, and there was actually a small increase in the NIH budget. So that's where I'm hopeful that legislatively they're not going to go as far into hurting our infrastructure as maybe some other places would be fine to do that pain to the infrastructure. That's not a great answer, but I think that's all I got right now.
Fair enough. We have one more question that hopefully is a little bit easier and more answerable. I think you talked about a lot about the problems with Medicare Advantage plans, and someone was asking, are there patients that you would recommend enrolling in Medicare Advantage plans? Like, are there certain people for whom they are beneficial?
Right. So Okay, it's actually funny because I've gotten into debates with some Mount Sinai faculty on this, and I do know that in a lot of places, beneficiaries are encouraged to disenroll from their plan and and go back on traditional fee for service. I think it's a rational choice for so many people to enroll in Medicare Advantage because of those gaps, like dental. Dental is a great example. Um, Without dental coverage, it might be unaffordable for you to pursue oral health. So the fact that you can enroll in Medicare Advantage and get that covered, that's a rational, viable, important opportunity, and so many other things. So right now, with the additional benefits, I would encourage people to enroll in Medicare Advantage if they can't otherwise afford things.
Got it. Thank you so much for the answers to those hard questions and for your whole talk. We really appreciate you coming today.
Thank you. Have a good day.